Thank you very much for a nice introduction. Will not take much time. This is my topic. There will be a little bit more explanation of the PSMA PET CT. Thank you, Catherine, for introducing that one. PSMA can be used in other cancer than the prostate cancer. I have no conflict of interest to disclose. There are some affiliations and my former affiliation with COVID Cancer Control Center and Jawar Molecular Imaging Center. So this is an outline of my presentation. So prostate specific membrane antigen is a glycoprotein, as you know that one. It is a glucosamidase carboxypeptidase, and it is usually expressed by the name. It is expressed in the prostate, but it can be expressed into benign conditions and a non-prostate other malignancies as well. It was discovered in 1987 by a prostate cancer line. It is a 750 amino acid transmembrane protein and is expressed in the short arm of chromosome 11. And I will not go into detail how it looked like. Here are two components, extracellular and intracellular, that use in the imaging and the theranostic purposes as well. So the history of PSMA is not, it is go back in 90s. We have a tracer Prostate, which having a lot of background activity. It was at that time it was in great interest, but because of the limitations of indium labeled, the pharmaceutical availability and lot of background activity is not popular as much. Then in 2000, breakthrough happened in 2011 by a German group. They make a gallium-68 PSMA molecule. This is a peptide, and by using a gallium generator. And since in the introduction, it was used in the prostate cancer for staging, restaging, and monitoring the therapy. Very good result of PSMA in prostate cancer, as every speaker mentioned that one. So what is the mechanism of, you should know that one, what is the mechanism of localization of PSMA in prostate cancer is a transmembrane protein. Is overexpressed in around 95% of the prostate cancer. Its density increases with the Gleason score and castration strata, and expression in case of dedifferentiation, metastatic or hormonal refractory disease, the expression is also increased. In non-prostate cancer, it is the PSMA expression is also seen in variety of malignancies. The PSMA expressed in the endotheliums of the tumor associated vasculatures of solid malignancy due to the tumor associated angiogenic factor and the endothelial cell sprouting. So that is the mechanism that the tumor has some new vascularization, and you can see the other tumor that are very highly vascular. You can PSMA can localize those tumors. The highly vascular tumors are like, for example, hepatocellular carcinoma, renal cell carcinomas, gliomas, especially high grade. They have high vascularity. So you by this mechanism you can localize these non-prostate cancers. So it also expresses in the inflammatory expressions like increase in PSMA legend, especially in because of the blood flow, vascular permeability, and especially the macrophages binding that cause the uptake of the PSMA in the inflammatory. You can see a lot of esophagitis, lung infection can localize the PSMA. So this is a very non-specific imaging. So the application will be the new vascularizations of other solid tumors. It can be used at initial staging, restaging, and it can give you an idea about the prognostic significance of PSMA imaging by telling you the aggressiveness of the disease. So these are the different examples. So we are looking for the 50 or many grades of PSMA, not message 50 grade, but I will show you the half of it, of the different shades of PSMA imaging in other tumor other than the prostate cancer. So number one is the gliomas, is the most common CNS tumors. The treatment is, as you know, that one will be a safe resection, and then you have adjuvant therapies like chemoradiation. The tumor specimens show that one there is a high PSMA expressions in gliomas, and as you know that the FDG is not good as in gliomas because of the normal tracer distribution of FDG in the brain parenchyma, and you will able to see a high grade tumor of gliomas, but low grade cannot be visualized on FDG. the PSMA is very good in it because they don't have a normal uptake in the brain. So this is a case of 42-year-old female with the GBM grade 4, treated with surgery, now presented with a headache. You can see hardly somebody can look at it, might find some equivocal findings, but obviously because of the high activity in the normal parenchyma, you are able to miss the gliomas. And this is the PET-CT images and the fused PET-MR. You can easily visualize the tumor here, and then you can look it back in the slices. Then you can see that one there might be have some equivocal uptake of FDG, but there's better localization of PSMA in gliomas. Another case, patient with GBM have a multiple resections. This is a multiple sites of GBM is there, and after resection you can see there is not only a single tumor, there are multiple tumors, and you can see it is not in the frontal lobe, it is in the posterior parietal region as well. So not only it can show you the localization, the multifocality, and initially now just we started by the radiotherapy planning and targeted therapy by using PSMA in gliomas. This is another case for target delineation, and you can see that one how good the PSMA localize the tumor, and it can help regarding the targeting the target delineation and using for the radiotherapy planning. And especially after the radiotherapy you see a lot of edema, and that limit the utility of MRI. So this is a functional imaging, tell you the residual tumor or the active tumor site showing the vasculature, and you can easily plan your therapy according to based on the treatment planning with PSMA. The studies have showed that one they are correlated with the KI index, the proliferation index. There are some certain studies they can show that one they have potential between the differentiating with the radiation post radiation necrosis versus the residual tumor. So it is very helpful, and it is a diagnostic challenge, especially to differentiate between the radiation necrosis and active tumor in any modality, especially the standard is MRI or FDG. So this is a better test to differentiate between the radiation necrosis and the recurrence. And there are the few proof of concept regarding the role of lutetium PSMA therapy in the cases of complicated gliomas. This is the case reported in 2020, and this patient underwent 3 cycles of lutetium therapy, and you can see that there has a very good objective and radiological response in this patient, and you can easily see that there is a reduce in uptake of this glioma tumor. The other main indication for non-prostate utilization of PSMA is a hepatocellular carcinoma. Why it is? Because FDG is little bit less useful in very well differentiated hepatocellular carcinoma. And still the contrast enhanced CT is a gold standard for the diagnostic and management of CA. Around 50% of the cases of FDGs are negative on hepatocellular carcinoma, so you need to look at it, how it is behave, and especially for the monitoring of the therapy. As you know that in hepatocellular carcinoma, targeted therapy uses the TKI plus immune checkpoint inhibitors. You need something to test functional imaging to see the response of the case. This is a very interesting case. Patient with a colorectal cancer now presented with a huge liver mass that might be a second primary, and you can easily see that there will be a very avid tumor in the liver, and it can show you the pattern of enhancement of that tumor, the highly vascular tumor. So PSMA expression in hepatocellular carcinoma is attributed to the new angiogenesis of the tumor. The PSMA uptake is correlated with the tumor aggressiveness, and there are studies that show that one of the study published in GNM 2021, they show that it will change the management of the hepatocellular carcinoma around 50% of the cases, and more than half% of cases you can change the management. Either you can able to see an unexpected metastasis side, and in those cases. So especially now there will be a lot of talk about the targeted therapy or some assessment with the like mapsagrine and angiogenetic inhibitor, that is the bevacizumab, and they are related to the angiogenetic activity. So you are a tracer, now you have a tracer that give you an idea about the tumor angiogenesis. So it will be very good regarding the evaluation of response to that therapy.
Dr. Sharjeel, 5 minutes to go.
Yeah, this is the one case. Another very good indication in renal cell carcinomas. Renal cell carcinoma, as you know, that there are very highly vascular tumor, and majority them of the renal cell carcinomas are the clear cell types. You see the more expression in the clear type rather than the other type of renal cell carcinoma. So in PSMA is much better than FDG, as you know that the FDG is not good in renal cell carcinoma. Around 70 to 80% tumor are not avid on FDG. So it not only localize the initial staging, and it can give you an idea of the metastatic involvement. This is the case. You can see the unexpected tumor metastasis in bone. Another case, unexpected metastasis seen in the brain metastasis with gallium 68 PSMA. The stronger the expression of PSMA, it gives you an idea about the high grade and poor overall survival rate. And it will be very good. Now you can know that one, the important role of TKI and immune checkpoint inhibitors in the treatment of metastatic renal cell carcinoma. So you need some tests for the response evaluation, as the FDG is not good at it. So PSMA have a very good role in the response evaluation, especially with TKI and immune checkpoint inhibitors. Other tumors, CA lung can be positive. Lobular cancer, which is not much avid on FDG if you're talking about the breast cancers, and the studies show that the PSMA expression see more in the hormone negative as compared to hormone positive. Another more important, that will be the hormonal refractory metastatic cancers. This is an example of lung adenocarcinoma, and there will be, you can see the PSMA expression in iodine refractory thyroid cancer. Again, you need a certain tracer that can target the radionuclide therapy. You can visualize, you can see what, and you can treat the other cancer. That's it.
Sum up, please.
Yes, I can skip those slides. I just want to show that one. Our case, the case of choriocarcinoma, the pre-therapy scan, the choriocarcinoma is a very, very aggressive tumor. You can't have much choices for the chemotherapy or other modality to treat those ones. If that tumor is positive on PSMA, if your therapies are exhausted, you can treat those patients. We treat with the 2 cycles of lutetium therapy, and you can see there is a significant reduction of PSMA expression, and the tumor drop from 50,000 the CA119 levels to 5,000 level, and patient survive for a quite bit longer time. So take home method, the PSMA can play a vital role in the other solid tumors other than the prostate cancer. The PSMA expression can influence the patient management, and it guides to the radionuclide therapy. PSMA, lutetium PSMA, it is here in the market for the prostate cancer. We should explore other horizon, other tumors. You can image those tumors, and if they are positive, you don't have any other choice, so you can treat those patients. Thank you very much.